Hi, this is Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. I want to welcome everyone to today's Journal Club. I would also like to thank ESGO and IJCS for their support in our Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. So participants with a camera turned on may appear in the video recording. We ask that everyone please keep your microphones muted so everyone can hear the presentation. And if you're having any difficulties or questions, please send a message in chat and our technical support will assist. We certainly have time for questions and answers, and we absolutely encourage everyone to submit questions via the chat function throughout today's session. So with that, I want to welcome Dr. Jason Wright, who is one of the authors of the lead article titled Modified Radical Hysterectomy for Stage 1B1 less than or equal to 2 centimeters cervical cancer, Assessment of Temporal Trends and Oncologic Outcomes in the United States. He is at the Division of Gynecologic Oncology in the Department of Obstetrics and Gynecology at Columbia University College of Physicians and Surgeons in New York. And certainly, of course, obviously, we also know him as the Editor-in-Chief of Obstetrics and Gynecology, the Green Journal. So I'm really very, very pleased to have you on the Journal Club. Jason, thank you so much. It's always great to see you. Really appreciate your accepting and taking the time to share discussion on this article with us today.
Great. Thank you so much, Pedro. It's a real pleasure to be here. I want to thank you and Arthur for number one, selecting our article and giving this opportunity. Also to thank the International Journal of Gynecologic Cancer and ESGO and IJCS for helping to sponsor this. And on this slide, I again just want to recognize all of my co-authors, in particular Koji Matsuo, who most of the folks on the call probably know or familiar with his work. He's just a prolific gynecologic oncologist at the University of Southern California. So Koji is in the OR today and could not join us. So I get the pleasure of presenting on behalf of the team. All right. So I'm going to talk a little bit about our paper today, looking at the use of modified radical hysterectomy for early stage cervical cancer. So just in the way of background, I think over the last decade, there's been a lot of interest in less radical surgery for early stage cervical cancer in the United States. There's been a body of evidence that's been generated suggesting that patients with low risk tumors, so early cervical cancers that are confined to the cervix, particularly small tumors with favorable pathologic characteristics, so no LVSI, favorable histologies, have a very low risk of spread to the parametrial soft tissue. So this has really given rise to the idea that maybe all of these patients do not need to undergo a radical hysterectomy and can have a more conservative surgical approach. Certainly over the last many decades, there's a large body of literature supporting the oncologic outcomes of radical hysterectomy, but the operation is also associated with fairly significant perioperative morbidity. So the ability to offer patients less radical surgery would hopefully be able to have equivalent oncologic outcomes, but with less morbidity for patients who are undergoing surgery. So the overall objective of our study was to really assess, number one, the temporal trends, and number two, the oncologic outcomes in patients with early cervical cancer. So we selected patients with stage 1B1 tumors that were less than or equal to 2 centimeters in diameter. And the specific goal of our study was to look at the role of modified radical hysterectomy for this patient population. So less than 2 centimeter tumors, comparing modified radical hysterectomy to traditional radical hysterectomy. This was a retrospective observational cohort study. So we relied on data from a large tumor registry in the United States called the National Cancer Database. This is a data source that's maintained by the Commission on Cancer, which is a large cancer governing body in the United States. And the National Cancer Database collects data on about 70% of incident cancers in the United States. So this is really across the entire U.S. of both community and academic hospitals and cancer centers. So we were able to identify 2,902 patients with clinical stage 1B1 cervical carcinomas that were less than or equal to 2 centimeters in diameter. Within our selection criteria, we selected patients based on their AJCC TNM stage, and specifically selected patients with a preoperative diagnosis of tumors that were 2 centimeters or less in diameter. So this was not their final pathologic diagnosis, but the preoperative assessment of tumor diameter. And we included patients who were treated from 2010 to 2022. We excluded patients who had primary radiation or any type of neoadjuvant therapy, either with chemotherapy or radiation. And we limited our cohort to patients with either squamous cell carcinomas, adenocarcinomas, or adenosquamous carcinomas. And the group was stratified into patients who underwent either radical hysterectomy, modified radical hysterectomy, or simple hysterectomy. On the graph on the left-hand side of this screen, you can see the overall trends and performance of each modality of hysterectomy for the cohort. Overall radical hysterectomy, so type C hysterectomy, radical hysterectomy, was the most commonly performed surgical procedure. You can see the numbers here, anywhere, depending on the year, from 40 to 50% approximately underwent a radical hysterectomy. The second most common modality of hysterectomy was a simple hysterectomy. This was based on coding in the NCDB, which was abstracted from operative reports. You can see that the use of simple hysterectomy increased from 2010 to about 2012, but then the trends in the rate of simple hysterectomy declined over time. And in the very bottom line, you can see the rate of modified radical hysterectomy, which showed an increase over time. So when we analyzed the trends for each of the 3 modalities of hysterectomy, there was a statistically significant increase in the rate of modified radical hysterectomy. You can see by 4.4% each year, and there was a statistically significant decrease in the rate of simple hysterectomy of 2.3% annually for that procedure. When we looked at the postoperative characteristics of the patient population, what we found is that LVSI was present in 23 to 26% of each cohort, which was statistically significant. So the rate is higher than some other studies that have looked at less radical surgery for early stage tumors. The rate of nodal disease was also similar across the 3 cohorts and ranged from 4 to 5%. The one difference in postoperative characteristics was the use of radiation therapy. This is external beam radiation with or without brachytherapy, was higher in those women who underwent a simple hysterectomy, so 18% versus 13% for the cohort that either received a radical or a modified radical hysterectomy. On the right-hand side of the slide, you can see the Kaplan-Meier curve looking at survival for the 3 modalities of hysterectomy. The percentages are 5-year survival, so overall there was no difference in survival for the cohorts. You can see for simple hyst, 95.8%, and for modified and radical hysterectomy, 96.3% and 96.6% respectively. So there was no statistically significant difference in survival. And as you can see, the Kaplan-Meier curves and the graph very similar and largely overlapping. When we did a multivariable model controlling for patient characteristics and treatment factors, there was also no difference in survival among the 3 cohorts. So comparing modified radical to radical hysterectomy, the hazard ratio was 1.23 for overall survival, which was not statistically significant, and the hazard ratio for simple versus radical hysterectomy was 1.02. So again, not statistically significant. So no difference in survival for any of the cohorts. Notably, within the data set, they measure overall survival. So this is overall survival and not cancer-specific survival. And we also lack data on recurrences. So we don't know recurrence patterns for these patients. We're only able to measure overall survival within the cohort. So, strengths of our study, I think inclusion of a large cohort of patients that we are able to analyze. Limitations of our study, as I said, this is data from tumor registry data. So we aren't able to verify the surgical procedure. The way the NCDB works is for the given surgical procedures, it's based on what the surgeon records as the operation. And then this is abstracted from the chart by trained chart abstractors within the NCDB. We also lack data on a number of important pathologic characteristics, including specifically margin status and depth of invasion, which are important factors in the selection and allocation of treatment for patients with early stage cervical cancer. Within the cohort, we also performed a number of subgroup analyses, and there was largely no difference in outcomes. Survival was similar based on histology, based on whether the procedure was a minimally invasive or an open surgical procedure. And in the sensitivity analyses, the only trend towards a decreased survival that was noted was for older patients, so patients greater than 50 years of age, where modified radical hysterectomy appeared to be inferior to radical hysterectomy. But all of the other subset analyses showed no difference in survival across the data sets. So I think this is certainly intriguing data. What we observed for this population was that there was no difference, largely no difference in survival for modified versus radical hysterectomy for 1B1 tumors less than or equal to 2 centimeters in size. Certainly, I think that this warrants further investigation. I think as we'll hopefully discuss in the question session, there has been more data that's now emerged on less radical surgery, particularly from the CONSERVE and the SHAPE trials. Our patient cohort is likely a slightly higher risk cohort than either of those cohorts, particularly the SHAPE cohorts. But I think encouraging results that survival was not inferior for those who had a modified radical hysterectomy. So thank you. I would be happy to answer any questions that you have. And thank you again for selecting our work.
Oh, of course. Well, Jason, thank you as always. Very articulate, and we really appreciate your overview of this manuscript and this important question. We have over 40 participants in the journal club. So again, really would love to see some questions from the chat group. And as always, we have our fellows participating. And I would like to ask the fellows to just state their name and where they're from, and then proceed with their question. And we'll start with Natalia.
Hello, thank you so much for the wonderful presentation. I am Natalia Teixeira, I'm from Barcelona. And I was wondering, your study found that the patients aged 50 years or older, for them, modified radical hysterectomy was associated with a decreased overall survival when compared to radical hysterectomy. What are your thoughts on why this particular age group might experience worse survival outcomes with modified radical hysterectomy compared to radical hysterectomy? Which factors do you believe could have contributed to this difference?
Yeah. Hi, Natalia. Thank you very much for your question. I think we don't know for certain what caused the increased mortality in the older patient population. I would say, a couple of caveats. Number one, when you look at the absolute survival difference in the older cohort, the patients greater than 50 years of age, it's actually quite small. It was only a 3.6% difference in mortality. So the difference is quite small. I think one limitation that we have is that, as I stated before, is that we're looking at overall survival and not either recurrences or cancer-specific survival. So particularly in older patients, we can't control for mortality for other causes, which definitely may play a role in this. I think I think the last point that I would make is within our study as well as within other studies. So when you look at SHAPE and CONSERVE, in all of the trials, the majority of patients have been younger. So in SHAPE, more than 3/4 of the patients were less than 50 years of age. So I think this is certainly warrants further investigation, and this is hypothesis generating. But again, I think that the survival difference is small, and we're not sure the exact factors that played into the survival differential.
And Jason, if I can just follow up to that, you mentioned that you did not look at recurrence or cancer-specific survival, and particularly for those who may not be as familiar with the National Cancer Database, and also actually a relevant point for many other databases. Oftentimes when our readers will look at a manuscript and say, I can't believe they didn't look at recurrence, or I can't believe they didn't look at this. Can you talk a little bit about availability of data in those
Sure.
databases?
Yeah, absolutely. I think, as Dr. Ramirez points out, I think we would love to have data on recurrences and cancer-specific survival. Unfortunately, we're really at the mercy of the data that's available in a given data set. So what the National Cancer Database tells us is the date of diagnosis, and it tells us the date of death of patients. So it doesn't tell us, number one, whether or not a patient has recurred, and it doesn't, number two, tell us what the cause of death is. So particularly in the older patients, we hypothesize that probably many of the deaths were due to intercurrent disease. So essentially other causes that we can't attribute to cancer. So I think you really have to look at the data set that you have available. There are some population data sets in the United States, like the SEER registry, where they do have information on cause of death, but cause of death is unfortunately not available in this data source.
Excellent. So thank you so much, Natalia, for that presentation and that question. And we'll turn over now to Filippo.
Hi, thank you, Dr. Wright. I'm Filippo Capomacchia from Candiolo Cancer Institute in Turin, Italy. So in your analysis, you compare outcomes of radical versus simple versus modified radical hysterectomy without stratifying patients by preoperative risk factors such as tumor size, histologic grade, lymphovascular space invasion. How you believe heterogeneity in these variables might have impacted surgical selection and survival outcomes? And what strategy would you recommend for future studies to incorporate preoperative risk stratification in choosing the surgical approach to adopt?
Yeah, Filippo, thank you so much for your question. So the question is, the stratification of risk factors. So we wanted to include a relatively broad cohort of patients with small cervical, what we thought were cervical confined tumors. So really our only selection criteria was based on tumor histology, number one, and on tumor, squamous, adenosquamous, or adenocarcinomas, and number two, size of the tumor, so less than or equal to 2 centimeters in diameter. We included patients regardless of their LVSI status within the tumor. As I noted, we did not have some criteria, some low-risk criteria that were defined by the SHAPE trial and other trials, including depth of invasion and margin status. So number one, I think we're limited again by some of the availability of data. But number two, we wanted to make this as broadly applicable as possible. I think the other important thing to recognize about this study, when you look back at our trends graph, we started collecting data all the way back in 2010. So this data spans over a decade, starting in 2010. So this was well before results of SHAPE and CONSERVE and some of the other trials looking at early stage cervical cancer were published. So really the first goal of this was not only to look at overall survival, but to look at temporal trends and how often less radical surgery was being utilized in the population. And again, when you were operating on a patient in 2015, we didn't have criteria for low versus high risk. Those are all relatively recent findings. So again, we wanted to be as inclusive as possible of small tumors, and selection was based on some of the limitations of the data set.
Excellent. Well, thank you, Filippo. And Jason, we have a question from Payam, and he's making a comment. Excellent presentation, Dr. Wright. Given the likely absence of data on LEAP versus cone prior to surgery, how do you think this limitation may impact your outcomes and recommendations regarding the choice between simple versus modified radical hysterectomy in this population?
Yeah, thank you for the question. We, again, unfortunately don't have data on whether cervical excisional procedure was performed preoperatively. Likewise, we don't have data on imaging, whether a preoperative MRI was performed on patients. So again, I think you can't directly compare these findings to the findings of SHAPE and some of the other trials where everyone either had imaging or had an excisional procedure, and all of the pathologic characteristics where you can classify these patients into a low-risk subgroup. I think particularly when you look at our cohort, so 26% of our cohort had LVSI compared to only about 13% in the SHAPE trial. So this is definitely going to be a higher risk cohort. So again, I think if you have a patient who has pathologic risk factors that meet low-risk criteria, I think those patients certainly are going to be candidates for a simple hysterectomy. I think, for the patients who potentially have early-stage cervical tumors that don't meet all of those low-risk criteria, I think I would use this as hypothesis-generating data, potentially to explore the value of less radical surgery in that cohort.
Excellent. So now we'll turn over to Frederick.
Thank you for the great presentation, Dr. Wright. I'm Friederike Stroisch. I'm from Heidelberg University Hospital in Germany. And my question is concerning the trend. So the data show an increasing trend for the modified radical hysterectomy of 4.4% per year compared to a decreasing rate of simple hysterectomies. What do you think could be underlying reasons for this development, and how might these trends evolve following the publications we just talked about, like the SHAPE trial, for example? These trials are advocating for de-escalation in surgical management.
Yeah. Yeah, I think, our trends definitely, number one, show an interest in less radical surgery. I would say when you look at this data, I think it should give everyone some pause and some caution. So back in 2010, there was very little data, let alone no prospective data on the safety of less radical surgery for stage 1B cervical cancers. In our cohort, 50% of patients were already having something less radical than a radical hysterectomy. So I think, this was driven by the fact that, number one, I think there's a pretty strong rationale that less radical surgery should be safe. I think, number two, by the fact that there were ongoing prospective trials looking at less radical surgery for cervical cancer. And I think, number three, when you look at oncologic surgery in general, there's been a trend towards less radical resections, whether this is, breast cancer, the things that we do, like vulvar cancer as GYN oncologists. So I think there were a number of trends that at play larger that probably drove what we saw in the lower rate of radical hysterectomy. But again, I would caution the widespread adoption of a procedure until there's safety that's been demonstrated. And, no one knows this more than Dr. Ramirez, in his work for MIS hysterectomy that was, again, widely adopted before there was good safety data. And his prospective work showed that we should have pause for minimally invasive surgery. So again, I think, it's somewhat concerning that there was limited data. I think, fortunately, the data that has emerged in this case has been more favorable for less radical surgery.
Excellent. Thank you, Federica. We'll turn over to our friend and colleague, Zaniru, from Mexico. Zaniru doesn't want to give up the radicality of his surgery, and he's asking, excellent article and discussion. While some centers continue to advocate for more radical procedures, such as total mesometrial resection, even in early-stage disease cancer, your study highlights a clear trend in the United States towards less radical surgery. Are we generally moving toward a simpler, safer approach, or could we be becoming too conservative? What do you believe drives these contrasting surgical philosophies?
Yeah, thank you for your question. I mean, I think undoubtedly we are moving towards a more conservative surgical approach for cervical cancer. I think to the point that I just raised to the last question, I think we do have to be cautious before we try to adopt surgical innovations to make sure that there is high quality data. I think for the question of early stage cervical cancer, certainly there's prospective data. SHAPE and CONSERVE are now available, suggesting that in a randomized controlled trial that simple hysterectomy is probably safe for early stage low risk cervical cancers. As I said earlier, I think our study should not change practice, but I think this is potentially hypothesis generating, that maybe some of those patients with small early tumors that don't fall into the low risk category, potentially these patients may be candidates for less radical surgery, like a modified radical hysterectomy compared to a class C radical hysterectomy. So again, I think it deserves further study. Completely agree with your point. Again, I think the oncologic outcomes for radical hysterectomy are obviously excellent, and we need to have good data before we move away from that.
Excellent. Thank you, Jason. And Zaniru Payam adds to your question, saying less is more attitude in some surgical management strategies. So thank you for that, Payam. And then again, commendable to Helena Overmeyer, who is in Sydney, Australia, and I believe is way past midnight. So thank you, Helena, for joining us from Australia.
Thank you. In your study, use of modified radical hysterectomy increased between 2013 and 2020. How do you think the subsequent publications of the SHAPE and JCOG 1001 trials will influence this trend?
Yeah, Helena, thanks for your question, and thanks for staying up late for the journal club. Yeah, I mean, I think even before SHAPE and the Japanese data were published, I think the trend was rapidly moving towards less radical surgery, and I think that will only continue. I think, you know, we now have better, higher quality data. I think even when you look in the United States at the NCCN criteria, you know, for those patients with early stage tumors with low risk disease, who've been assessed either with an excisional treatment or an MRI, that the conservative surgery is recommended. So I think we'll continue to see that. Again, I think, you know, as I've stated, our population was a little bit higher risk. We don't know, you know, the margin status of the patients. We don't know depth of invasion. So hopefully this is going to spur further investigation. You know, again, I don't mean to sound like a broken record, but again, one thing that I would caution is, you know, before we move too far away from radical surgery, we need to make sure it's safe. So I think that, you know, the bar is moving pretty rapidly towards less radical surgery, but we do need to be cautious and make sure, you know, that we test these interventions before they're extended too far.
Excellent. Thank you, Helena. And again, yes, I echo. Thank you for staying up late for the journal club. So now we'll turn over to Marina Rosano.
Thank you. So my question is related to the previous topic on the National Cancer Database. Given that recurrence data and site of recurrence were not available in the National Cancer Database, do you think their inclusion could impact surgical decision-making between radical, modified radical, and simple hysterectomy in early stage cervical cancer?
Yeah, thanks for your question, Marina. I mean, I think undoubtedly, you know, as Pedro alluded to earlier, ideally we would be able to look at recurrences. We would be able to look at patterns of recurrences, and we would have cancer-specific survival in this data set, and we don't. I think, you know, that one thing that everybody needs to keep in mind with a study like this using observational data, it's certainly, you know, at risk for selection bias. So again, we didn't randomize patients. There were undoubtedly, you know, patient characteristics, clinical characteristics that weren't measured, that went into the decision on whether to perform a simple, a modified, or a radical hysterectomy, which could have influenced outcomes. So again, that's why I've made the comment that I don't think we can use data like this to change practice, but it can inform the design of future trials. You know, certainly I think just if you think logically, if you have a patient who you think is higher risk for recurrence, you know, based on whatever factor, even if it's not measured, you're probably more likely to do a radical hysterectomy in that patient than one of these less radical surgical procedures. So there's definitely the possibility that those who had a radical hysterectomy had, you know, whatever it is, less favorable characteristics we just can't measure in the covariates and the variables that we have in our data.
Excellent. Well, thank you for that question. And we'll turn now to Italy. Sophia.
Good afternoon. Thank you. In the presentation, you mentioned that although the overall survival outcomes were similar across hysterectomy types, the use of adjuvant radiotherapy was either in the simple hysterectomy group pattern.
Yeah, you cut off there briefly. I think the question was the higher use of adjuvant radiotherapy in the simple hysterectomy group.
Yeah.
Correct. Yeah. Yeah. Thank you for your question. So when you look at our data, it was the absolute difference in use of RT, and this is whole pelvic plus or minus brachytherapy, was about 5%. So in the modified rad-hist group and the radical hist group, it was 13% versus 18% in the simple hysterectomy group. I think it's probably a number of factors at play. I mean, number one is I just, you know, highlighted, this is observational data, so there could likely be you know, a number of unmeasured confounding factors. You know, we lack data on margin status. We lacked data on other preoperative factors if patients had a conization, if they had an MRI. So I think my guess would be that for those patients who had a simple hysterectomy, there was more concern on their clinicians about the potential of positive margins or some other adverse factor that we just can't measure, and that's what led to the difference in adjuvant therapy rates.
Yeah. Thank you, Sophia. Yeah, and also I'm sure, Jason, just to add to that, is that I'm sure this reflects also many of the patients that have surgery elsewhere, and then they come to the gynecologic oncologist who basically obviously was not there for the surgery, not really sure what the details were, the discussions about indications, and they just say, well, we didn't do the surgery, you had a simple hysterectomy, we're adding radiation, even if that may not be solely indicated on risk factors. So
yeah, absolutely agree. And again, I think, to that point, many of these patients were long before, SHAPE and the recent risk stratification. So, in 2014, if you had a patient with a 2-centimeter tumor who had a simple hysterectomy, many of us would have offered either a parametrectomy or adjuvant radiation at that point. So.
Excellent. All right, we'll turn over to Luisa.
Yes, good afternoon. My name is Luisa Proppe from the University Hospital Münster from Germany. And I've got a follow-up question to the one of Sophia. So as you already said, you had quite a lot of patients who had both radiotherapy and surgical treatment with hysterectomy. And given all these factors you already explained, do you think, or how do you think do these factors influence the results of your study, or how do you interpret these relatively high proportion of patients getting 2 therapies, adjuvant and surgical treatment, instead of unimodal treatment?
Yeah, certainly. I mean, I think, definitely, our cohort, there's a relatively high, rate of use of radiation therapy compared to what you may expect. I think, as I suggested earlier, this is definitely a higher risk cohort than the SHAPE cohort. The rate of node METs in our cohort was almost 5%, and the rate of LVSI was more than double what they saw in the SHAPE cohort. So this is not limited just to those patients with small cervical tumors with all favorable prognostic factors. I think, again, that's potentially, within this study, that the fact that we included some higher risk patients because we lack the data to stratify them into the low risk group, the fact that some high risk patients were included. I think, number one, I think that's important that this, there may be a role for modified radical hysterectomy in patients who don't meet strict low risk criteria with small volume tumors. But it's also a limitation. So we have to balance the potential increased need for radiotherapy, particularly in those patients who had a simple hysterectomy. So again, I think it's, you have to look at the pros and cons and the trade-offs, particularly if this is studied further in a prospective manner.
Excellent. And now we'll turn to Reem and her beautiful baby. And I see that we have done an amazing job in putting your baby to sleep with this journal club. So Jason and I will not take this personal. In fact, actually, we'll be very proud of the fact that we have done that. So thank you so much, obviously, for joining, and look forward to your question.
Thank you for this presentation. I just have a question. In practice, when we consider the de-escalation to modified radical hysterectomy, should we consider sentinel lymph node biopsy for these tumors less than 2 centimeters before considering the de-escalation?
Yeah, absolutely. Yeah. Congratulations on your baby, and thank you for your question. Yeah, I mean, I think the first point would be, for this patient population, just because we're doing a less radical local resection and not performing a parametrectomy and upper vaginectomy, these patients still should undergo nodal evaluation. So they're still at risk for nodes. So I think patients need to undergo some type of nodal evaluation. In my opinion, this is probably an ideal population to do a sentinel lymph node evaluation on. When you look at the sentinel lymph node data, the rate of detection is highest in in the small volume tumors. And we know that the rate of detecting microscopic nodal disease is higher if you do a sentinel lymph node compared to just a full lymphadenectomy. So I think that's certainly reasonable. When you look at the NCCN guidelines, again, in the United States, they recommend either a sentinel lymph node dissection or a full pelvic lymphadenectomy. So I think clinically, either, I think both are reasonable, just depending on, your resource availability and your expertise.
Excellent. Thank you, Reem, for joining. And again, congratulations. Beautiful baby. Future gynecologic oncologist, maybe, with all these discussions surrounding at this very early age. And so now we'll turn to Mariana.
Hello, thank you so much. My name is Mariana from Brazil. You already mentioned some aspects of my question. You mentioned that the absence of pathological data was a major limitation and that your findings are hypothesis generating. But how do you think the interpretation on oncologic outcomes could have been different depending on the proportion of patients with low versus high risk criteria based on pathological findings, if you had this data and if you stratified according to these high or low risk factors?
Yeah, thank you for your question. Very thoughtful. This is a question we've obviously thought a lot about. It is a limitation, and again, undoubtedly, this is a higher risk cohort than those patients in SHAPE who just had all low risk criteria. I think it's hard to know for sure. I think that's why we need more probably prospective study in large cohorts that are looking at patients who have a combination of these higher risk features and still, small volume cervical tumors. I think if we could have pulled out just the high risk patient population, I think, that the data is pretty similar, even when you try to stratify, we didn't present the data, but by different histologies, we presented that, but by, the 1 to 2 versus less than 1 centimeter tumor, all of the sub-analyses that we did suggested that survival was fairly similar across the 3 modalities of hysterectomy. But having said that caveat, you really can't be certain if the high risk patients were excluded, what the findings would be, or if we had high risk, we limited the study to high risk patients. I again suspect if this was just low risk, I think our data would have replicated SHAPE. I think there would have been no difference in survival across the modalities of hysterectomy. I'm less certain about if we did a study limited to patients who did not meet the low risk criteria for SHAPE.
Excellent. Well, Jason, I certainly want to thank you, of course, obviously, for addressing all of these questions. And before we close, actually, I would love to hear your thoughts, going a little bit beyond this group. Obviously, we're talking about the less than 2 centimeters, but love to hear your comments about, when we have patients 2 to 4 centimeters, a fair number of those patients today end up getting chemotherapy and radiation. And in fact, actually, if you look at the more than 3 centimeters, a fairly high percent, up to 70% of those patients potentially also getting chemo radiation. Oftentimes, the reason for the chemo radiation are positive lymph nodes, deep stromal invasion. It's, I think, rare that the only reason that they will be getting chemo radiation is because of positive parametrium. So with that, do you see that at some point in the future, we're going to be discussing simple hysterectomies or modified radical hysterectomies for 2 to 4 centimeters, knowing that a high percentage of those patients are going to get chemoradiation, or potentially, again, not even actually going to surgery for those patients? Just to love to hear your thoughts on that.
Yeah. Always thought-provoking and tough questions from Dr. Ramirez. So thank you. I think the short answer is that it will probably evolve that way. And it's, the more I've thought about it, it's exactly what you said. I mean, the question before was really, for these early stage patients, are we subjecting patients to dual modality therapy who maybe wouldn't need that by doing a simple hysterectomy? For the patients with bigger tumors, if a large percentage are going to require radiation anyway, then why subject them to the morbidity of a radical hysterectomy? As you said, the chance of isolated parametrial disease is pretty small in this cohort. So I think it's definitely an intriguing study and question. I think we need more study, but I could see surgical practice patterns, evolving that way over time. Absolutely.
Great. Well, thank you again so much, Jason. It's so much fun always to listen to you, and I learned so much. Always great to see you as well. I want to thank everyone that joined for the Journal Club, those who submitted your questions. Of course, I want to thank all of the fellows for the fantastic job that they're doing on the fellowship, for staying up throughout all of the regions of the world that have attended. And thank you again to ESGO and IJGCS for supporting these journal clubs. I also just wanted to remind everybody, the July Journal Club is going to be with Diletta Fumagalli, who is going to be presenting on the topic, Rewinding the Clock on Positive Peritoneal Cytology and Endometrial Cancer. Does it predict prognosis in low-risk disease? So it sounds like we may be going back to the routine days of cytology on everyone with endometrial cancer. So looking forward to that discussion. But once again, Jason, thank you so much for joining us, and for all of the current fellows and former fellows that have also joined as well.
Thanks, everyone.
Thank you. Bye.